All right. So welcome back to Ultrasound Grand Rounds again this week. I'm excited to be here again. It's a nice sunny day here in Cleveland. It's a great day to be talking about ultrasound. And what we're going to do today is we're going to wrap up this series that we've been talking about, left ventricular ejection fraction assessment in the emergency department. The previous weeks we did endpoint septal separation and fractional shortening. Today, we're going to do the visual estimate technique for ejection fraction of the left ventricle. Let's dig into it and talk about EF assessment with the visual estimation technique. So the last couple weeks in our discussion, in our conversations, we've been going through various different methods for determining left ventricular ejection fraction. So this all came up over the course of the last several months as I've been looking through some of our QI and really wanting to dial in our ability in the emergency department to just hit that left ventricular ejection fraction just solidly every time we see it and every time we write up a report, so that when our cardiologists look at our images, they can say, hey, these are quality images. We really trust what the ED is putting out. And so to that end, I've been doing this 3-part series, and this will wrap up kind of the 3-part series of how do we determine this left ventricular ejection fraction. And so today is going to be the final part. We talked about endpoint septal separation. We talked about fractional shortening. And then today we're going to talk about just the visual estimation. So let's look at it and just pick a number and see, what that ejection fraction is. So as we get started, we're going to open up with that case that we've been using for these 3 different lectures, right? And so imagine yourself in the emergency department taking care of patients. And this is not too hard to do. I mean, I've been having a number of clinical shifts the last several days in the ED, and I've seen a number of patients that could plausibly fit this, again, hypothetical scenario. But imagine you're seeing a 65-year-old gentleman complaining of shortness of breath. Vital signs are as indicated. So not horrible, but they're, not amazing. And they say, hey, this has been going on for about a week now, kind of worsening shortness of breath. I can normally walk pretty good. Now I can't really walk very far without getting decently winded, but don't have any chest pain. It's getting into cold and flu season, so at least here in the United States. And so there's no URI symptoms, no fever, no cough, congestion, other than just kind of this feeling of being winded, right? And so we kind of go through our exam, again, the same that we've been seeing the last couple of weeks. A little bit of an obese gentleman, regular rate and rhythm, no murmurs, rubs, or gallops, some trace rouse in the bases, abdomen soft, some edema pitting edema in the lower extremities, and the skin is warm and dry. Past medical history of hypertension, hyperlipidemia, diabetes type 2. So again, painting this picture, and we're going to buzz through the introductory part of it because, we've been talking about this case for the last couple of weeks. And so we know that this is going to end up being a patient with heart failure. And so while there's an exhaustive differential diagnosis, we're going to narrow in to this differential diagnosis of heart failure using our EKG, our chest X-ray labs, and then ultimately, kind of skipping through some of this stuff, ultimately getting to that echocardiogram, right? This is going to be the sine qua non of this diagnosis, where we want to see exactly what this heart is doing, how well it's functioning, how well it's pumping, if there's any restrictions to pumping, things like that. We're looking at that to help us make the diagnosis for this patient. So again, we're looking at effusion, chamber size, valvular problems, blood flow through it. What's the ejection fraction? And so again, just for a reminder, anything that's less than about 50% for an ejection fraction, we're going to be considering normal for these conversations. Generally normal is somewhere in that 55 to 60% range and above. And there's multiple ways of getting after this. And so we're going to look with our ultrasound. We're going to see here, like on the left is a decently normal ejection fraction. Here on the right, kind of a low ejection fraction. And how do we make that determination other than just looking at, hundreds and hundreds and hundreds of different echoes? And so again, in the spirit of this review, we've been talking about some different tools that we can use to bring to the bedside to help us really dial in that left ventricular ejection fraction estimation. And those tools, just as a reminder, was this endpoint septal separation technique, where we drew an M mode caliper right through the mitral valve leaflet tip in the parasternal long axis window. We got this tracing, and we measured the distance from the leaflet to the septum, as you can see on the right-hand side of this screen here. And anything that is less than 7 millimeters is considered to be normal left ventricular ejection fraction. Anything that's greater than 7 millimeters is of varying degrees a decreased ejection fraction. If you want some more details on that, go back to the YouTube channel, look up the EPSS for left ventricular ejection fraction lecture that's on there. You can get the nice long version. I also have a couple little short videos if you want a quick hit right on your shift, 1 to 2 minutes of how does this, how do you do this? How do you perform this? It's also on the YouTube channel. You go check check that out. But that's technique number one that we talked about. Technique number two, which we did last time, was this fractional shortening method, right? And so this was basically moving that M mode caliper just a little bit further into the ventricle, right? The widest part of that ventricle, and then measuring the tracing of the anterior wall and the posterior wall of that left ventricle and how much those two came together during the systolic cycle, and measuring the difference in the percent change, right? And so we're going to put that into the formula end diastolic diameter versus end systolic diameter of the left ventricle. Subtract that, all that over the left ventricular end diastolic diameter times 100 to make it a percent, and we're going to get something that approximates one of these numbers, right? And if it's in that 25 to 45% range for fractional change, that is normal or correlates with the normal ejection fraction. And then if we're less than that, 20 to 25%, looking at the moderately reduced, and then less than 20%, we're looking at severely reduced. And we can see two different ways of getting to this left ventricular ejection fracture. One is looking at flow through a valve and how the chamber responds, in the settings of varying degrees of ejection fraction, deficits, right? And then the second one is looking more of like, what is the actual chamber size doing in the fractional shortening? So those are two different techniques. If you want to know the fractional shortening, the video posted last week for that one on the YouTube channel. I've also got some shorts there as well you can look at. But today, what I want to do is really dive into this third technique. And this is going to be probably what we do most of the time, right? The first one that we're going to actually utilize. And then probably the fastest one as we're looking at how to estimate the ejection fraction using, in this situation, the visual estimate technique. And this is where I found that for the most part, we do a great job, right? And then there's an occasional case where our estimations kind of break down. And hopefully in the context of this lecture, we can go through some specific tools that we can think through as we're doing this visual estimate technique to really improve the quality of that LVEF that we're trying to assess, right? But before we get into that, I want to show you a couple articles to prove that I'm not making this stuff up, and this is actually supported in the literature. And if you look at the literature, there's a number of articles that go back into the 80s and 90s. We're not going to get into that. I want to look at two in particular. This is the International Journal of Cardiology 2005, and they basically showed that the visual estimate technique for ejection fraction by echo correlated with other formal methods of doing it. So if you look on kind of my graphic here on the right-hand side of the screen, the article looked at several different methods of estimating ejection fractions. So AV plane displacement, fractional shortening, the Simpsons 4-chamber, Simpsons biplane, wall motion scores, various different scoring here, and then compared it to a cardiologist assessment, visual estimate of, you just look at it and be like, that one looks like it's about 45. That one looks like it's about 25. That one looks like it's normal. And what they found is these correlation coefficients. And what I want to focus in on is the Simpsons biplane, because this is really the standard that we use. If you read through the echo reports that we put up at our institution, and probably most institutions, that stacked discs that we talked about last time, the Simpsons biplane, there's a R value of I got to make this a little bit bigger so I can see it here, 0.898. So a decent R value for these patients when you're doing this visual estimate compared to Simpsons biplane. So as these cardiologists get skilled at doing this, they look at it, I wonder what this is. They do the Simpsons and they correlate with what they said, and congratulations, you're getting pretty good. The question, though, is can we, as emergency physicians, do this at the bedside? And so the next article I'd like to point to you is this article from Academic Emergency Medicine in 2003, where basically it's entitled Accuracy of Emergency Physician Assessment of Left Ventricular Ejection Fraction and Central Venous Pressure Using Echocardiography. So we ignored, at least in this discussion, the CVP estimation, but they did kind of two things in this study. But the first one is, can you estimate as an emergency doc that's LVEF, and are you any good at it? And so what they did is they basically took a whole bunch of patients and they did a bedside echo. They had the ED doc say, this is what we think it is. And then they had the patient get a comprehensive echo, and they excluded patients who had like an echo today and then a comprehensive 3 weeks from now. That doesn't make any sense. It had to be within 4 hours, I think, of each other, some limited time range, and said, how good are they at doing this? And what they did is they broke it down into broad categories. Is it normal? Is it reduced? Is it severely reduced? And they looked at cardiologists, and they looked at EP providers, and they broke them down into those different categories, and they ended up with like a 9x9 table. You have normal, reduced, severely reduced, normal, reduced, severely reduced for both providers, and then how much overlap of patients were there in each of those categories when we, like basically how many of the times did we agree? And so what they found is in the normal category, EP physicians and cardiologists agreed 92% of the time, right? Really, really good. When it got less than that, it deviated a little bit. So interestingly, the moderately reduced was about a 47% agreement, and the severely reduced was 70%. So it kind of shows that when you're kind of in that gray zone, there may be a little bit of discrepancy. And we're talking about small numbers here, so it wasn't a very large trial. But when they did in aggregate, what is the overall agreement between cardiologists and EP physicians? He's found about a 78% agreement with a kappa of 0.71. So statistically, it's not perfect. They're not 1-to-1, but we're never going to have like two people. Well, if we take 10 people and show them the same thing, they're probably never going to agree on everything. But from a statistical standpoint, a kappa of 0.71 is not bad, right? It shows that, as ED physicians, we are pretty good at estimating the left ventricular ejection fraction, particularly the normal ones, in comparing that to what the cardiologist is going to get when they look at it later with their studies. So with that said, let's dive into kind of what are we going to look at here and how do we really improve our estimation of this left ventricular ejection fraction. So as we get into it, just remind ourselves what is happening right in this left ventricle. What do we estimating? I think we have to know, before we can figure out how to get better at the thing, we have to really know what that thing is. And so just as a reminder, when we are looking at this contraction, right, this left ventricular ejection fraction, we're really trying to estimate the strength of the contraction and how effective or how forceful that contraction is and how good it is about getting blood out of the chamber. And so when we look at it, remember from last time, we talked about there's multiple different fiber orientations in the left ventricle that can cause a left ventricle to contract kind of in that fashion of wringing a rag. And so when you look at the heart in different angles, you're going to see different aspects of that contraction. And we have to kind of map that out in our heads and come up with I think it changes about this much percent, right? And so in the long axis views, like the apical, the parasternal long, the subcostal views, we're going to see a lot of motion kind of inward and a little bit downward, right? We're going to see some motion of that mitral valve kind of annulus moving up and down. In fact, there's a method called mitral valve annular systolic plane excursion, or MAPSI. We have some longitudinal movement. There's going to be a lot of oblique movement, which we're really not going to see distinctly, but we know that it's there. And then when we go in short axis, we see a lot of radial movement, a lot of movement of the chamber inward, right? And so last time what we did is we tried to mathematically kind of show this, right? To prove this and to use some math to really tell us what we're doing. And so we use this idea of, an ellipse, right? Or a parabola, I guess, and graphing down there, and just reminded ourselves way back when, however long ago it was for you guys, when you did college level calculus, right? And you integrated the area under the curve, you can really use that to develop an understanding of the volume under that curve. And so essentially this is what the Simpsons biplane or the Simpsons disk method of disks is it creates these volumetric disks mathematically, stacks them one on top of each other to approximate the interior dimensions of this left ventricle, and measures it in systole and measures it in diastole. And we put up the integration here just to show kind of how mathematically it could work. But essentially that's what's happening. The machine is taking this data and calculating volume out of these stacked coins or stacked disks, in its largest diameter, in its smallest diameter, and those are volumes, right? It's measuring volumes in those two different components of that cardiac cycle, and then comparing those volumes and telling you how much of that was ejected from the ventricle when it was filled and when it was squeezed. And so getting back to this, we're looking at the volume change between systole and diastole. And when we put the math around that, right, that's what we call the Simpsons method. And so when we kind of translate this over to our visual estimate, we are kind of almost doing the Simpsons method in our head, right? We're kind of figuring out multidimensionally what is the volume inside this heart in its widest dimension and what is it in its smallest dimension, and kind of in our heads calculating mathematically how much do we think that's moving, and then reporting that out in broad terms. It's reporting reasonably normally, a little less than what I expect to be normal, or really a lot less than what I expect to be normal. But as we get into that, there's a couple different things that I want to focus on as we try to increase our accuracy, other than just kind of like, I'm going to spitball it and think it's pretty close to this. So let's think about this. There are two main factors that are responsible for the change in ventricular volume or chamber volume, because that's essentially what we're getting at. How do I estimate the chamber volume in its widest, in its smallest diameter or sizes? And so the two factors that really come into play that help us understand this volume, and we probably do this a little bit without realizing it, is there's going to be some degree of wall thickening, right? And there's going to be some degree of wall excursion. And when we pair those two together in multiple views, we get this idea of what type of work that chamber is doing. And so let's think about this one by one. Let's break them down a little bit, kind of take it outside the context of the heart, think about that a little bit, and then apply it back to the heart. So for wall thickening, right? Remember, the heart is a muscle, right? It's a bunch of myocardial fibers that are arranged in a certain orientation, and that when they contract, they thicken, right? And so think about it in the context of any other muscle, right? So here's just a long axis of kind of more of a linear muscle, and we see on the left in its relaxed state, and we see on the right in its contracted state, and we can see that there's a thickening. And if you remember back to our physiology, there's the actin, the myosin filaments that are overlapping with one another. And then when you have a signal, right, when there's an electrical signal that hits the myocyte, it releases calcium. The calcium then triggers the activation of these actin and myosin filaments, and then they walk along each other and they shrink down. And instead of being all stretched out and kind of narrow, they kind of crunch up and they become a little bit thicker, right? Very broad terms for what's happening. The muscular physiologist would be ashamed at this point at that level of discussion. But in broad terms, which is what we're trying to do right now, as you take that certain length, that certain volume of a muscle, and you make it shorter, that volume has to then go somewhere else, and it results in a thickening of that muscle. And that's exactly what we see here when you look at this muscle, or when you go to the gym and you flex your arm, and all of a sudden, your bicep gets really big, right? So applying that back to now the heart, we can see that the heart muscle is made up of multiple different layers, right? So the endocardium, the myocardium, the epicardium, as we see here. And as that muscle gets stimulated, right, as it contracts, it's going to thicken. Now, unlike a bicep, or unlike some other muscle that's in that long axis where all the fibers are going in one way and it's going to thicken in one direction, the heart has multiple fibers in multiple different directions. And so, it's going to contract in that direction, but it's also going to thicken kind of in this, the endocardium to epicardium direction, right? And so we'll see that happen in the heart. And so as we think about this volume change, one of the key factors in this contractility of the heart is the ability of the muscle fibers to move and to create that tension. And we see that expressed in this ability to thicken of the myocardial wall. So again, this is one of the critical components and indicators of the muscle being able to do its job. And so in the left, we see it in the parasternal long axis, and in the right, what we see in the parasternal short is the exact same thing, but throughout the circumference of the heart. And so yes, it's important to look at how much this thing thickens, right? But it's also important to look at what part of the muscle is thickening. And so you can have patients with myocardial scars or ischemic, regional wall motion abnormalities or things to that effect, where you see a portion of the muscle thickening, right? And you see a portion of the muscle not thickening. And so one of the other aspects here, as you're looking at this to kind of mentally take note of, is the entire ventricular wall thickening as it goes throughout its cardiac cycle. And I love the parasternal short axis window for this, because you can almost, mentally put a dot in the middle, or sometimes I'll put my finger on the screen and watch all those different segments around the circle and see if they move towards my finger and if they all thicken around that circumference, as it goes to, as I, look at my finger. And so this is an important element to think through as we're figuring out this ejection fraction. The second one, right, we talked about those two factors that, relate to the ability of the myocardium to do its work. The second one is what we call wall excursion. So again, going back to that example of a linear muscle, right? It's going to do work, right? Remember the physics equation, force times distance equals the work, or the work is equal to force times distance. So the second way to think about this is the movement component of a muscle. So if we think about muscles broadly, they are essentially designed to create movement, right? The muscle fibers are designed to create movement. And when we span a joint, right, when the muscle spans across, the elbow joint, the knee joint, the shoulder joint, whatever joint we're talking about, when that contracts, it causes that joint to move. And that's what we call a range of motion, right? The extent to which any part of the body can be moved around a fixed point, right? And so as you think about it, again, we'll take the bicep. You can have a pretty broad range of motion for this thing. You can extend your arm out nearly straight. And then when you curl your bicep, you can get your wrist to almost touch your shoulder if you have a really good range of motion. But we also know that, if you're lazy and don't do the curl, you can do a half curl and do like partial range of motion, right? So there's a very broad range where you can get this muscle to move this joint across this distance, right? And if we think about it, we throw a picture in here, we can see here's a guy doing flies, and you can see the range of the motion of that pec muscle and that shoulder muscle that he's working is kind of this really broad distance that this muscular contraction is causing this arm to move. And so I guess I show this by analogy to say the heart, while it's not a muscle that's oriented across a joint, right? The heart is going to create some form of contraction, result in some form of movement. And that movement is kind of almost the range of motion of the heart, right? That wall excursion. And so factor number 2 that we need to look at is not just does the muscle thicken when it contracts, but how far does that go when it's contracting? And so what we're going to see in the left-hand image of the parasternal long and the right-hand image of the parasternal short is as we watch that muscle wall, right, we're going to watch that muscle wall move inward, right? And there's going to be a certain amount of movement that happens as that muscle contracts that results in a change in the chamber size, right? The range of motion of that muscle, or that cardiac muscle, right? So here's another couple examples of apical four-chamber. And I'm going to prove this to you, right? That this range of motion, right? That this thickening is going to be the two factors that are really important in figuring out the chamber size. So as we take a step back and think about what we're trying to accomplish here, we are trying to estimate the volume that's pumped out of the left ventricle with each beat as expressed as a percentage, right? So the small, the large, do the math. It's a percentage change of that volume from the endocardial. And we see this. Let me back up. We measure this volume as, the distance from the endocardial wall, right? And so as we think through the Simpsons method, we stack these discs up. They kind of stop at the inside of the chamber, along the endocardial wall. And so as we piece this together, we have to remember, okay, we see the thickening, we see the movement. What do we see in the thickening and the movement do? And what do we really care about in this context? And that is the volume change, right? And so we want to know how much blood is inside that chamber, right? Between endocardial wall to endocardial wall. And as it moves, as it thickens, it's going to decrease that chamber size, right? And that's what we're going to see kind of in this stacked discs. And if we look last time at the fractional shortening, we're starting to get at that with this whole idea of the ventricle contracts. We see a change in the diameter, right? Endocardial border to endocardial border from the anterior to the posterior wall, and measuring that change in that length of the border of this heart. And so that's essentially what we're trying to get at here as we look at this wall excursion, right? We're trying to, look at how does this thickening, how does this movement relate to that endocardial border, right? Which then is translating into the volume that this heart is experiencing in diastole and then in systole when it squeezes, right? So with that being said, that broad kind of understanding or background of, the two different factors that result in this change in volume that we're looking for, how do we interpret that? Let's look at some examples of what we're trying to find, right? What we're trying to see, so that when we go to the bedside and then correlate it with, what we're seeing at the bedside, we can kind of know where our patients fall on this continuum. So how to interpret these findings? Let's break this down. So here is an example of normal, right? And we're defining normal as, above 50 to 55%. And so if you think about it, the heart is not 100% efficient, right? It doesn't pump out every ounce of blood that it can on every single beat. And I'm sure we could come up with some teleological arguments for that. The first one that comes off the top of my mind is, well, then that wouldn't have any ability to increase the amount of blood if we all of a sudden needed increased blood flow, right? So let's say you start running, you need to, have increased blood flow to support your increased metabolic demands. If you squeezed everything out at every single beat, well, there'd be no ability to ramp that up and increase that. So maybe that's a crude teleological argument, but, it reinforces the point that the heart pumps out between 50 and 60% of its contents with every beat, right? So we don't expect to see complete collapse. And so as we look here, we can see the heart in this peristernal long axis and in kind of a quasi-apical view. And we can see that there's a decent squeeze, but it doesn't completely empty itself out every single beat, right? And what we want to do as we're assessing this is we really want to scrutinize, where is that endocardial border? And we'll get to this as a pitfall, but I'll say it now in case I forget. If you cannot visualize the endocardial border, you're going to have a really hard time of being accurate when you assess the left ventricular ejection fraction. In fact, I had an example of this yesterday that I QA'd, where the images it was really hard to see the endocardial border, at least in the ones that were stored, right, or archived. And so when the person says, hey, this is what the ejection fraction is, it's really hard to say I agree or disagree, because you don't see that endocardial border and really the definition of what is the confines of that volume of the left ventricle. So here we see on the left side, we can see the endocardial border pretty sharp in the peristernal long, maybe a little fuzzier, but we still see enough in that apical floor that we can assess for how much wall excursion is there, right? A decent amount. Is there thickening circumferentially around the entire border of the heart that we're seeing? And the answer is yes. And both sides kind of give the same type of a story. So moving to the next category, let's look at the reduced ejection fraction, right? And so again, I present these in broad terms, right? I think if you're doing a quantitative measurement, like a Simpsons measurement, you're going to get a number, right? And a lot of machines these days that are coming out on the market have automated ejection fraction, estimations in there. They have, some method of the Simpsons method that it uses AI tools to essentially, create or get the images that you want or the clips that you want, and then gives you this number, some of them decently in real time. And so that's helpful as coming, but as we kind of assess this ourselves, we're going to broadly categorize this as normal, then reduced, and then severely reduced. And I think for emergency department purposes, that's probably reasonably fine. But as we look at this, we can kind of go back to those two different features. Number one, do I see the endocardial border? Yes. And then is there movement in the ventricle? How much movement is there? And then is there circumferential thickening of this ventricle? And so yes, there's thickening, but we can see compared to the previous one that there's a reasonably reduced degree of movement, right? There's a reasonably reduced degree of thickening in this particular heart. And so we can categorize this as a very much reduced ejection fraction in this patient. And then compare that then to the third broad category, and that's the severely reduced, right? And so we see, again, applying those same principles, do we see the endocardial border? Yes, we see that. Is there thickening of the wall circumferentially? Well, as we look at this one, there's very little appreciable thickening of this wall, right? Which means, and it translates into the fact that there's very little actual wall excursion that's happening here. There's the chamber size between systole and diastole is not appreciably different. In fact, one of the things that we notice here is that the left ventricle is pretty profoundly enlarged, right? And this tells me essentially that this patient has had a very, very high left ventricular pressure for quite some time that has resulted in some remodeling and some dilation here. And that pressure is largely probably due to the fact that the patient has had pretty low ejection fraction for a decent amount of time. And so those are the three examples of normal, reduced, severely reduced that we can kind of set as our benchmarks as we're looking through this visual estimation technique. So as we conclude today, what I'd like to do is walk through a number of pitfalls, a number of areas where, I've seen that you can get yourself in trouble as you're trying to interpret this, and where you may struggle, or where maybe to say it better, we find limitations in our ability to estimate the left ventricular ejection fraction based on visual methods, and we'd have to, rely on some other techniques to help us out, right? So there's pitfalls can be broadly categorized into, a couple different categories. One is these technical pitfalls, things that, we can improve our technique to get better at. And then the other one's patient-related pitfalls, where we may struggle with certain classes or categories of patients, right? So technical pitfalls, the first one is foreshortened windows. So the predicate the sine qua non of this technique is you actually have to have a good image, right? You have to have, see the ventricle in its entirety. And so I'm going to point to this one here. This is a rotational foreshortened. You can also have it longitudinally foreshortened, but essentially we're not looking at the entirety of the ventricle. And so we see a good view of the right ventricle, but when you looked at the left ventricle, we're really seeing not much of it at all. And so it's really hard to get an accurate estimate of what the left ventricular ejection fraction is when you don't actually look at the left ventricle in its entirety. And so it's really important as you do your scanning, as you try to estimate this left ventricular ejection fraction, that you find the window where the left ventricle is viewed in its largest, most full dimensions, right? And so you can do this rotationally, where you rotate your transducer to emphasize the right ventricle versus the left ventricle. You can also do this longitudinally if you are angled inappropriately, usually in the apical window. You can, emphasize more of the ventricle, you can emphasize more of the atria. And if you aren't doing that view straight through the ventricle, straight through the valve, all the way to the apex, getting kind of that little bit of a point at the end, you're not necessarily going to get the full left ventricle, which means you're going to have an insufficient view to get an accurate left ventricular ejection fraction assessment, right? So that's number one. That's the technical limitation number one. Number two is if you have incomplete windows, right? And this one kind of is similar, but from a different perspective. Like, let's say you have a imaged left ventricle. Here we go. There's the apical window. There's no foreshortening here, but I have some lung shadowing on the right-hand side of the screen that is overlapping that left ventricle. Now, we could probably extrapolate in our mind's eye, what may be where that border is. And if we kind of scoot our probe around, we can see through it. And, so one image doesn't tell the whole story, right? You can probably work through this. But if you have an incomplete window where the lung is curtaining over top of a portion of that ventricle and you cannot then see that ventricle, you do not have a sufficient view of that left ventricle to be able to say definitively that this is what you're looking at. And so really, to be most accurate, you have to have an assessment of the entirety of that left ventricle in the window that you're looking at, or supplement it with other windows to be able to kind of fill in the pieces where the image is lacking, essentially, right? So that's technical pitfall number two. The third one is inadequate windows. And this is what I was getting at earlier, what I really wanted to lean into and talk about and emphasize in this discussion. And that is, you need to be able to see the endocardial border, right? And so in this left-hand image, we see that there's a heart, right? We see that the heart is beating, but the gain is set low enough, and the window is inappropriate enough that I don't really see the accurate and actual outline of what's left ventricle, what's right ventricle, and I don't really see the endocardial border, right? And so I can say it's beating, right? It doesn't look like it's distressed or anything to that effect, but I have a really hard time saying, is this a normal ejection fraction? Is it a reduced ejection fraction? Because I really don't have a volume, basis to look at, right? Maybe the one on the right here with the apical 4 is a little bit easier, but again, it's really hard to see that endocardial border to really say, okay, what is my actual systolic volume? What is my actual diastolic volume, and be able to mentally compare those. And so as you are trying to get your windows for your ejection fraction assessment, make sure you can actually see that endocardial border, right? So walk through this mental step or thought process in your head is, do I have an adequately visualized ventricle, right? If I got it rotationally, appropriate, longitudinally appropriate, is there anything overlying that? Can I see the interior diameter or interior border of that chamber? And then once I do that, is that wall thickening? Is it moving? What degree to it? What is the degree to which that's doing that? And that's all going to go together as you work through this mental algorithm to figure out your left ventricular ejection fraction, right? So that's, that technical piece. Here's an example that's a little bit better, right? On the parasternal short, we can see that endocardial border a lot better. The parasternal long here is still struggling a bit. So reduced ejection fraction is what it seems, but it's really hard to call that definitively until we have an improved border. Right. And so putting all these together, again, in this patient, one of the windows is decent, right? But the other windows are a little bit challenging to see, and it makes it kind of hard to assess this left ventricular ejection fraction, right? So those three pitfalls said, right, we're going to move into some patient-related pitfalls where you may struggle to come up with an accurate left ventricular ejection fraction, right? And the first one, the most common one that I run into is tachycardia, right? So if the patient is super tachycardic, it can look like the patient's hyperdynamic. And I've seen a lot of these in my QA where the report will say there was hyperdynamic left ventricular ejection fraction. And you look at it and the patient's tacking away at 110, 120, 130 beats a minute, right? And so it's fast, but when you slow it down and look at it, when you look at the actual chamber size difference, right? There's not as much chamber size as you would want to see for a hyperdynamic patient, right? And so tachycardia is a great masker of a low ejection fraction, in this visual estimation technique. So one thing that you have to be careful of is when you see the super tachycardic patient that you really scrutinize, these steps that we talked about. Do I see the border? Is the wall excursion, appropriate? Is the wall thickening appropriate? And then if you are struggling with that, take a clip, right? Slow that clip down, whether you turn the cine loop speed on your playback down, or you just slowly scroll through the cine. And what is that chamber doing kind of as you take the speed component away and look at it, compared to the other one. And so what you'll see in these hyperdynamic patients, right, the patients that have a really super duper high ejection fraction, is that the walls will get really close to each other. What we call them kissing ventricles, where you have the walls kind of squeezing every ounce of blood out. I was trying to look through my archive and I didn't find one, but classic example that I've seen a number of times is GSW that's hypovolemic, right? The patient's bleeding out somewhere. The heart is trying to respond by ramping up its speed to be able to get as much blood to the tissues to perfuse, but there's no blood to perfuse, and so the LV is just empty, right? We'll see a similar example later. But you may see that hyperdynamic compared with something like this, where it's probably a little bit reduced, even though the left ventricular ejection fraction is reduced, even though the rate is increased, is what I'm trying to get at here. The next one that I just alluded to is hypovolemia, and these can be challenging. So here's an example of basically an LV that's not filling, right? And so I guess by definition, proportionally, every ejection is squeezing a large amount of blood out. But is it just that the patient's super duper hypovolemic, or are they that good at doing what they do? And so again, these can be challenging, especially if the patient has a known history of something like mildly reduced ejection or moderately reduced ejection fraction, and then also have a hypovolemic event. So you have to look clinically at what the patient's doing, right? What is the broad picture looking like as you're assessing this, right? Because this isn't going to rule in or out heart failure, if the patient's super duper hypovolemic. And so what's the IVC look like? Is there anything in the pericardium? What is the myocardial wall doing essentially, right? The third one that's challenging on a similar note is this left ventricular hypertrophy. So as hearts are put under greater and greater afterload stress, right? They're going to remodel, they're going to hypertrophy, and become thicker and thicker and thicker. And so this can have the appearance of, moving quite well, but again, you have to look at kind of what's the wall doing, what's that relative chamber size. You can have decently thickened and hypertrophied hearts and low ejection fractions. And the final one that I wanted to lean into that will be a little bit tricky is what happens if you have regional wall motion abnormalities, right? And so here's an example that we can see where we have some violation of those two principles, right? We look at the wall excursion, we look at the wall thickening, and we can see that there's a discordance between different places in the ventricle. So in the apical floor, you see some good movement in the base here, and you see a lot of poor movement in the apex. And so where this can be challenging is, ultimately at the end of the day, like if the wall's not moving and the heart's not pumping, your ejection fraction is going to be low. But where it's going to be challenging is you may not see that in all your windows. And so one of the things that comes up is, well, what happens if you see a normal ejection fraction in one window and you see something really abnormal in another window? And so this is a good opportunity to really start backing up and asking ourselves, okay, well, why am I seeing this, right? Am I accurate in one window or the other, right? Can I use other tools to help guide me along, EPSS or fractional shortening? Or is there some reason why one window is not working and the other one is? In this situation, we have a wall motion abnormality where we can see a portion of that wall is not functioning as efficiently as the other portions of the wall. And you may or may not see that in other different windows of the heart. In fact, you can see, the apical is contracting in a certain way here. The parasternal long has got, a lot, it looks like it's a lot decreased in terms of ejection fraction. And the parasternal short, you can see, well, I guess some of it's working, some of it's not, and kind of see where that wall motion abnormality is. So that's the fourth and final pitfall for the patient related. So as we kind of back things up, just to review, we were talking about left ventricular ejection fraction. There's multiple ways of getting after this, right? EPSS, fractional shortening, visual estimate are the three big ones that we're going to use. The best is to use a combination of all of these to really get an accurate multidimensional picture of what this patient's heart is doing. But as pertains to the visual estimate, we're looking specifically for what is the volume chamber or the chamber volume in its systole, biggest diastole and its smallest systole, and that is influenced by the thickening of the ventricle, the excursion of the ventricle, as we look through these different images. All right, so hopefully that was helpful for you guys as we think through this idea of left ventricular ejection fraction assessment. Now we have three tools to use in our toolbox: visual estimate technique, the EPSS technique, the fractional shortening technique. If you want to go back and review any of those, hit up those lectures on the YouTube channel. If you found this information useful, interesting, definitely hit that subscribe button, hit that notification bell so you can be notified every single time we publish a new video. And feel free to share with your friends and leave us a comment in the comments below how you think this is helpful, particular things that you might like or things that you want to add to the conversation. If you're interested in learning about the training that we do here for medical students, residents, fellows, metrohealth.org/POCUS. Otherwise, we'll see you next time for the next video, and check out the video on the end screen here. See you guys. Bye.